Welcome everyone. Welcome to the Demystifying Dementia webinar 2. Acknowledgement of country. I'd like to begin by acknowledging the traditional owners of the land on which we meet today, the Ngunnawal people, and I pay my respects to elders past and present and emerging. If everyone could please add their full name in your profile just so we can track who is present. Use the question and answer function. And we are recording the session if everyone is happy with that. And at the end, there is a evaluation form that we would like you to complete. The learning outcomes for session 2, describe best practice post-diagnostic care for a person living with dementia, modify risk factors that both reduce risk of dementia, delay the onset and slow the progression of dementia, implement the effective management plan for people living with dementia based on stages and domains of dementia, appreciate the impacts of caring for someone living with dementia. Today is presented by ACT Health, the Health Pathway Program and Illawarra. You can see that there's usernames for ACT and Southern New South Wales and Illawarra, and there's a QR code if you would like to access that. So we have 8 clinical dementia pathways in our Health Pathway Suite, Dementia Health Pathway Suite, which the 8 are listed there clinically, and we've got 2 request page or referral pages that are listed over here. Our 2 speakers today are Dr. Karen Savery and Dr. Rebecca Moore. And Dr. Savery will speak first. I think over to you.
Perfect. You can stop sharing.
Okay.
Yeah, thank you.
Karen, you're on mute.
Welcome back to Dementia Demystified Session 2. Thanks, Beck, for letting me know that I was about to start talking and nobody would hear. So as Sharon's already let you know, this is really our next step. So our first workshop was around how do we identify people that might have dementia, what are we looking for, what sorts of things are involved in making a diagnosis, and this workshop is really about how can we modify risk factors that might delay or prevent the onset and progression of dementia, and what to do once you have identified that somebody has dementia. You've either made that diagnosis or referred them for a diagnosis. What next? So the what next is really what we're talking about tonight. And we really want you to take away that there is actually a percentage of dementia that is probably attributable to some modifiable risk factors. So we are going to talk about that tonight. And that for most people living with dementia, there are things that we as GPs can do from both the diagnosis and initial management, as well as some of those treatments and things that we can put in place that do improve people's quality of care when they are living with dementia and for their care partners as well. So just a reminder, we're more than happy to answer questions along the way. If we're able to, feel free to use that Q&A panel. If we need to, we'll answer live, or we might type a response depending on what the question is. If we know we're coming to it, we might park it for when we actually get to it. So just a bit of a recap. So your apple table penny moment from the last session, we spoke about the domains of dementia. And this is really useful when we're both thinking about our history taking, but also as we come to think about management as well. So all of those areas that dementia can affect. So we spoke about that sort of cognitive decline. So not just memory, although that certainly is often one of the more evident things, the short-term memory loss, but also things like executive function and planning, things like being able to hold attention, being able to follow a storyline or a conversation, that language changes that comes under cognition, some of our verbal fluency or empty language, the thing that does, we're seeing that real word finding difficulties. And then some of the more motor things that might occur as people forget how to use common implements, or things like handwriting. We spoke about functional declines. As cognition declines, so does function. So again, thinking about that person in front of you might be having trouble with things that they've always been able to do, whether that be use their remote, work out how to send an email, use a spreadsheet if they were an accountant. So really looking at changes in function is something we see as well. We spoke about some of the psychiatric symptoms that we see, and that can be things like anxiety or depression around the time of diagnosis or during the course of the illness. We certainly spoke about some of the hallucinations and delusions that might occur, and we can see that in up to 50% of people with Alzheimer's dementia. We spoke about some of those early behaviour changes that we might see in early on, so things like irritability or withdrawing from hobbies or social contact, as well as the behaviour changes that we might think about when we're thinking about dementia, somebody that can't express their needs so much anymore, so might be calling out or wandering or agitated. And finally, we spoke about that sort of physical decline that happens. So early on, it might be certainly looking at things like stride length changing. And then as the disease progresses, really seeing things like the decline in mobility, being sort of bed-bound or chair-bound, being unable to independently do some of those ADLs anymore, incontinence, so certainly those physical changes. So we spoke about how to think about that with history, and we're going to come back to that as we think about our management as well. Beck, do you want to remind us about the stages of dementia that we spoke about?
Certainly. So just as it's really important that we think about the domains of dementia as the condition progresses, I think it's also really important to remind ourselves of the stages. As you may remember, generally we would start with a period of what's known as mild cognitive impairment. Now, this doesn't always transfer into a dementia disorder, but about 50% of the time, over time, mild cognitive impairment will become a dementia. And really the difference is that with mild cognitive impairment, you will notice some objective cognitive changes, but people will still be able to manage their activities of daily living and instrumental sort of activities like cooking, cleaning, shopping, etc., without any significant impairment in function. They may use compensatory mechanisms, but essentially we would class that as mild cognitive impairment. So stage 1 is when we start to notice some functional changes. As all of these go on, as Karen was saying, there is a possibility of the mental health changes that come and go, and similarly behavioural changes, which tend to come on more strongly in stage 2 and then stage 3. So often in terms of behaviour, you're going to see changes like the apathy and the withdrawal fairly early on. Stage 2, you might start to notice some other behavioural changes, and also that's when we'll start to see more of those physical signs as well. So increase in falls risk, incontinence. And these are often sort of the times when family start to find it very increasingly difficult to care for a person at home. And so at around sort of the stage 2, stage 3, that's when often a decision might be made with the family in terms of moving somebody into more residential care facilities. And then stage 3, there is a significant change in physical function and in cognition, and often the person will require extra assistance with things like feeding, communication, bathing, etc. So we have a mantra really in stage 1. It's looking at dignity through independence. Stage 2, dignity through safety. And stage 3, dignity and comfort. So just to recap, the inclusion and exclusion criteria in terms of making a diagnosis for dementia. Really, there are 4 inclusion criteria. Firstly, you need to notice a change in cognition, which is gradual in onset, okay? About 85% of the time with Alzheimer's dementia, there will be some sort of change to memory. So you need gradual onset. There needs to be progression in the decline of the cognition. That is, it's getting worse. And it needs, as I've said, to affect function. And then the 4th criteria is that there's nothing else it could be. And so in terms of the other things it could be, we need to exclude a delirium. We need to look at other medications, alcohol and alcohol withdrawal. We need to consider other mental health conditions. Particularly, we know that depression can often mimic a dementia. And also, often it is tricky in a person who has pre-existing mental health conditions like schizophrenia or bipolar disorder to sometimes differentiate one from the other. So this might be the sort of time where specialist input is required. And then finally, other organic causes. So this is the things like hypothyroidism, low vitamin B12, space-occupying lesions, etc. All right. So, Karen, let's backtrack a little bit. What we can do to try and mitigate our risk?
So we certainly know when we looked, when the Lancet Commission looked in 2020, that they identified that there were some modifiable risk factors that actually we could mitigate early, but it was never too early or too late to start looking at modifying them. So the earlier we consider it, we may certainly delay the onset or may delay completely the risk of dementia. But even when somebody has a diagnosis of dementia, it's still worth looking at the modifiable risk factors. So what did they identify? And this was a worldwide, looked over a number of countries to try and pull out from the studies what might be risk factors for dementia. And these were the 12 things that were definitely able to be pulled out. A lot of these we're already monitoring and managing, but it just gives us a different way of kind of framing some of these things, which for some of our patients, you know, thinking about it as a rather than a cardiovascular risk as being a dementia risk may be enough to motivate someone to make some changes. But we certainly know that smoking, physical activity, hypertension, obesity, you know, diabetes, all of those things we're actually managing reasonably well now. And they're certainly things that we want to keep managing when somebody has a diagnosis of dementia. Some of the other things we're seeing a lot more in the news now about some of the head injuries, particularly sports-related head injuries, but we also think about victims of domestic violence or other people who may be having recurrent head injuries as potentially being a risk down the track. Infrequent social contact was another one that came up as a modifiable risk factor, as was hearing impairment. So again, certainly in that 45 to 49-year-old health check, which we are enumerated reasonably well to go through with somebody what their risk factors might be. I'm picking up quite a number of women often with hearing impairment who ordinarily might not have done anything about it, apart from the fact when we're thinking about it as brain health, it has been more motivating. So we know that in Australia, when they pulled out the Australian data, the three that came up most as being the largest impact in trying to modify the risk of dementia was physical inactivity, obesity, and hearing impairment. So certainly things that we can target from middle age or even earlier, as well as once we actually make a diagnosis. Something that we can do with our patients if they're interested, and probably before I move on, the two things that we can't influence as much is air pollution. But certainly we do have some doctors groups who are certainly very interested in looking into air pollution and education as well. So certainly across the world, but in Australia as well, those that didn't complete more than 8 years of formal education as children were more at risk, and that's down to having not having that same cognitive reserve, so that if you're losing some of that function, it might be evident more early than if somebody has been educated past that time. So one of the things we can do with our patients that are interested, there is an assessment tool called the CogD risk, which is validated and designed in Australia. So if your patients are interested, you can send them away with this to actually do, and it looks at a whole heap of demographics and other things and comes up, and you can do it from the age of 18, but it's really giving you that risk profile from 65. But it does give a whole heap of resource sheets around some of the things that are identified as well. So it's just another way of having the conversation, but also hopefully down the track in destigmatizing brain health, because obviously that terminology dementia, people are still fairly frightened of, or we know there's still a stigma around it. So the more we can kind of bring it into our conversations as part of brain health, it's really just reframing some of what we're doing already. We'll just have a look at some of the questions you're typing when.
Yeah, sorry, I've just answered that question. It was just a question about what to do if somebody has mild cognitive impairment but no obvious risk factors. And I just said, look, the really good evidence is for physical activity. And so certainly we would be encouraging physical activity in all our patients, as well as monitoring and managing vascular risk. There is some evidence for a Mediterranean style diet, and so I'd be encouraging that type of nutrition, limiting alcohol intake, and also, again, there's some evidence for some cognitive stimulation. And like Karen was saying, whilst we can't change education in childhood, there are some studies going on. There's a big one in Tasmania where people in later life are attending university, and there is some evidence to suggest that even later life learning might be somewhat protective. Just reading the next one. Oh, yes, and University of the Third Age. I think that's excellent. Excellent.
So we might recap Anna. Beck, do you want to remind us about Anna, who we met in the last workshop?
Yes, so you may remember Anna's in her early 70s, and she came in because she had forgotten her flu vaccination, or she'd missed her flu vaccine. She'd come in with her daughter Sophie, and it became evident that Sophie had had some concerns about Anna's memory. Anna had started to be less well groomed. She'd started to leave a whole portion of the garden, which had been previously her pride and joy. She'd left the stove on a couple of times. She'd been forgetting to take some medications, etc. And so Dr. George organised a history and examination. And as you can see from her results, there is certainly evidence that Anna has some challenges with cognition. Her mini mental score was 22 out of 30, and you can see from her clock drawing task that she struggled with that as well. Functionally, as we've said, there were some issues, and otherwise there were no other criteria that would suggest a different cause. So I think the next slide, we've got a video of Dr. George discussing her diagnosis.
So again, as you're watching it, think about what things you liked about Dr. George's way he did it. We're not saying that's the only way to do it. And what would you do differently? So it's always good to reflect on how you might, talk about a diagnosis with the patient sitting in front of you.
So Anna, I've had a good look at all of your results, and I'm pleased to say the blood tests are all completely normal and the brain scan showed no sign of a brain tumour.
Okay, good.
But what that means is that the likely diagnosis for the cause of the changes that have occurred for you over the last 6 to 12 months is a form of dementia.
So that's like Alzheimer's.
Like Alzheimer's. I guess I'm just interested to know in this situation, what do you already know about dementia?
Well, not very much, I must admit. I've never really thought about it. I guess it's one of those things you tend to put off in the too hard basket or something. So I don't know a lot, really. So perhaps if you could explain it to me.
I certainly can explain it to you, and then I'll also suggest for you where you can have some more information that you can perhaps look at together in your own time, because there'll be so much for you to take in today.
Yeah.
It's a lot, isn't it?
Oh, certainly is. Well,
You knew something was going on, Mum.
oh, no, I suppose I had a bit of a thing and I put it off and didn't like to think about it. Yeah.
So now it's time to start thinking about it.
And is there medications that she can take, or is there any sort of treatment that's available for?
There are some medications that are available. They can slow the progress of a dementia in the early stages.
Okay.
They are not a cure. They help a person to maintain their level of functioning for a longer period of time. And that's really the goal now, is to help you maintain your current level of functioning as long as possible.
Right.
Because it's likely in the future that your level of functioning, your memory and your ability to do things that you can currently do will be not as good.
Mum lives by herself at the moment. She's still generally quite capable, like going twice a day. She's still okay to be at home by herself.
I think that's certainly the case at the moment, and we'll be able to organise together some support to help keep you at home as long as you would like, assuming that's what you would like.
Oh, absolutely. Oh, I want to be home.
So I think the main thing from here is for you to have an opportunity to say what you want.
It's such a lot to take in, isn't it?
It is a lot to take in.
So that's something I'd have to think about and get advice about.
And the good thing is that we've got time to do that.
Good.
We don't have to do everything today.
Oh.
So my goal for you, Anna, is to the best of my ability, is to honour what your wishes are.
Right.
In order for me to do that, I'll need to know what your wishes are.
Yes, yeah.
And that's the thing that together we'll work out some plans to make sure, like, for example, to help you stay in your home as long as possible.
Yes, I'm determined to do that as much as I can.
So, Anna, I've had a
We might pause it there. And we don't need you to type anything into the chat box, but just think about if you were giving a diagnosis to someone with dementia, how you would do it. And think about the things that Dr. George did well, or maybe the things that you might do differently. Certainly the things that I appreciate from Dr. George is he keeps Anna very much in the centre. He's talking to her, he's very respectful, and certainly not just talking to a family member. So it is something that's worth remembering when we are talking to someone who does have a diagnosis of dementia. Anything else you would comment about that consultation, Beck?
Well, I do appreciate the fact that he uses the term dementia. I think sometimes we try and beat around the bush, but actually I think giving a diagnosis of dementia is really important. I also appreciate the fact that it says that this will happen over several consultations, because it is a discussion I think that you keep coming back to. And as you know, I think often that first consultation when you're giving difficult news, most of it's a bit of a blur, and most of the time the person doesn't remember much more beyond the diagnosis itself. Yeah.
Great. So what we're going to move on to now is thinking about management. And the management approach is going to change depending on what stage a person is in, but some of them are certainly going to be very similar. So we're certainly wanting to keep the person central to the process. We certainly want to allow that discussion time, and it may well, and it will likely, occur over a number of consultations. And again, in general practice, we've got the beauty of being able to follow up and to be able to spend time with people over time. We don't have to do it all in one consultation. We spoke in the first workshop about language and using language that is respectful and non-stigmatizing language. So being aware again when we're talking to a person who's living with dementia about that. Obviously, we're going to look at the other medical conditions they have. We've spoke about some of those modifiable risk factors already. If we can, we want to involve the person's care partner, which might be family, it might be a neighbour, it might be somebody else that's involved. But if we can involve their carer, then that's always useful. And that multidisciplinary approach is always going to be valuable when we're managing somebody who does have some cognitive impairment. And we'll talk as we go along about the sort of strengths-based approach. We're really wanting to help the person keep their things that they're strong at while putting in supports for the things that they might not be managing as well. So for example, if somebody's having difficulty with cooking, if we just come through and take out everything they're doing cooking-wise, they will de-skill quite quickly. But there might be things that we can put in place to help them do some things in the kitchen for longer, which is that strengths-based approach.
I was reading somewhere, Karen, that often reading is a skill that is maintained, quite a long way into the process, and that, for example, reading is a really good thing that most people living with dementia can continue to do for a long time. So it just resonated with me. It might be helpful to some of the listeners.
I certainly have a number of my patients in residential aged care who still read or want to read the newspaper. So that's been part of the routine for a long time, and they keep enjoying that. Somebody's put Sorry. I was going to say somebody's put in the
I was just
questions.
going to say.
You go for it.
I was just going to say it's a nice thing they can do with their grandchildren as well.
Yeah. Absolutely. So somebody's put flagging potential diagnostic possibilities so that it's not a complete surprise when they come back for a diagnosis, and absolutely agree. And I think in this particular case, if we watched all the videos, she was quite worried about having a brain tumour, hence him leading off with the comments about it not being that, but hopefully some of that is flagged so it's not a complete surprise when they get a diagnosis. Great. So Bex alluded to this already, but really our goals of care do change as we move through the various stages of dementia. So that mild cognitive impairment, we're really looking at maintaining cognition and functioning. So looking at those modifiable risk factors. And in fact, the management is very similar to stage 1, except for not using Alzheimer's specific medication, but really looking at what we can do to support cognition and function with the hope that we actually don't see progression through to dementia. Stage 1, when people are often still living at home, we're really looking at trying to maintain independence and enjoyment, looking at those modifiable risk factors, looking at what other services and that sort of multidisciplinary approach we can put in to help people maintain independence for as long as possible. As those care needs escalate in stage 2, it really is about dignity through safety. So that might be requiring far more care at home. It might be looking at moving into residential aged care. So depending on what supports they have around them. By stage 3, when they're really looking at being fully independent for all ADLs, we're looking at 24-hour care, whether that be in home or in residential aged care. And our goals of care change. So we're no longer thinking about those sort of modifiable risk factors. We're looking at comfort. We're looking at quality of life rather than quantity of life. So depending on where people are along that trajectory, our goals of care will change. We're going to concentrate mostly tonight on that sort of stage 1, because that's when we're thinking about community general practice, that's where we're seeing most people who are in stage 1 dementia. So we said before we can use those domains to help us take a history. We can also use them to kind of remind ourselves of what sorts of things we need to think about in our management. Now, you might use these as part of a general practice management plan. You might just use it as something that you tick through over a number of weeks or months through consultations, but we're sort of thinking about that cognition and mental health. So how can we support those domains? We're thinking about that sort of functional domain. So what sorts of things is the person having trouble with, and how can we best support that function? And then there's some of the physical changes that might be occurring, or the modifiable risk factors that we need to be aware of. And then some of the behavioural side of things too. So we can use those domains to help us plan our plan of attack, if you like, when we're thinking about management. And we can do all of these things while waiting for a diagnosis also. If you have someone that you're fairly sure has dementia, and it's going to take 6 months or more to be seen in a memory clinic, you can actually do a lot of this along the way. So it's not something that you have to wait for. Lots of the suggestions within here would be useful whether someone ends up with a final diagnosis or not, but if they do, then they've got that extra support waiting for them. What we don't want is to leave people hanging for months and months while they're waiting for diagnosis, when there are actually things we can put in place before that time. So back thinking about education, what sorts of things would you be looking at?
Sure. So actually, can I just mention too that Dementia Training Australia actually have that checklist on the web page as well. So you can download that, and it's quite handy because it's just a little bit of a reminder of all the things that we recommend that you do. So as I said, like in regards to education, I think that very first consult when you're giving the diagnosis, it often is all a bit of a blur. And I suppose we all have different ways of doing things, but at that time, I tend to refer the person and their carer to the Dementia Australia website, which I find is very helpful. There's a number that they can call if they would like to speak to a human about things. There are also several help sheets, which are very helpful not only for the person and their carers, but actually also for the health professionals as well. There are help sheets on all the different types of dementia, on behavioural changes, on medications, on Suvenaid. So I'd strongly recommend, if you haven't already had a look at what's available, to have a look. Also, there's another really good website, I think we've got it on the next slide, called Forward with Dementia. That's a fairly new initiative, but again, that's got quite a lot of good information, particularly around the time of diagnosis, just some recommendations as to how you tell people, or, you know, which friends, which people you tell first, etc. There's quite a few good handouts on that as well. Where I have worked previously, regionally, we had a fantastic community dementia nurse, and I notice, I think a bit later, there's some talks at the very end of this about your PHN. It looks like your PHN has some separate handouts that they've done for particular local support. So I'd urge you to take a look at that as well. And I believe that there's a referral pathway for a community dementia nurse through your PHN as well. So yeah, there are things just to consider. Also, having a scout around for any dementia support groups, knowing what's available in your area is a really good idea.
I had a patient that really found the dementia support groups through Dementia Australia were invaluable for both himself and for his family as well. So lots of tips shared about different OT things. He was able to tell the group what the OT driving assessment was like. So they were able to kind of share information with people who are going through similar things. So definitely worth having a look at. There's the
Yeah,
Forward with
so they're
Dementia.
two really good websites to be familiar with. Yeah. Now, the other thing that I do quite early in the piece, and I'm sure you probably are the same, if the person has not already registered with My Aged Care, I strongly recommend that they do it very early on. In the area that I work, there's often quite a delay from even having the assessment to actually receiving provision of what's been recommended. And so I think the sooner that you start that journey, the better. I also recommend, where possible, they actually have the assessment at the house. So I think there's a box you can tick that says for a RIC referral, but if you can, ask them to tick the box for home assessment, unless you feel that they're really travelling very well. The Carer Gateway is another really good referral pathway, and I've had people use this particularly for emergency respite and that sort of thing as well. So two good things to consider.
There's a question there. Can carers access that support even if the patient does not agree that they have dementia or need care? Tricky situation for a patient who's a carer. They certainly can access the Dementia Australia supports and information sheets. The challenge with My Aged Care is you need the person's permission. So that's probably tricky for that situation.
Having said that, you can sometimes get a bit of a workaround if the person, so the husband looking after the wife, might require some help as well. So you can sometimes get them out, and that's enough to sort of ease the way. But yeah, it is a difficult time.
Because as we spoke about last time, insight is one thing that often is affected with dementia. So it is part of that cognitive decline that we do see for some of our people who are living with dementia is actually that lack of insight. So it is tricky. Don't tell us about the delirium action plan, Beck.
Yeah, look, again, this is something that you can download from the Dementia Training Australia website, and some of the PHNs have it as well. But we would recommend that you discuss delirium with both the person and their carer, because people living with dementia are a much greater risk of developing a delirium. And I think being aware that it's a possibility and knowing how to recognise it early is really important. So, yeah, we would also recommend that you give them a copy of the delirium action plan.
So we spoke a little bit earlier about, you know, the things that we can do to kind of modify our risk factors, but it's never too late. So for somebody who has got a diagnosis of dementia, looking at some of these things to maintain their cognition, or at least to continue to support them, particularly things like physical activity and social connection, really important to look at, as well as trying to modify some of those other risk factors which we're already aware of as GPs, our obesity, our diabetes, our blood pressure, excessive alcohol, so more than the sort of 3 standard drinks a day. So those things are still useful to address even once somebody has a diagnosis of dementia. So it is worth considering, again, from a cognitive support, what else we can do to try and maintain their cognition for as long as we can. Mood change is obviously something that we need to just be aware of as well. It can be tricky teasing out that sort of anxiety, depression, but we do want to be able to treat that as best we can as well, because that will potentially also impact on cognition. So we sort of, as part of that, we also think about medication. So this is kind of a crossover between function and cognition, but thinking about how we can support someone in managing their medication. So again, thinking about the barriers to actually taking it. Are people remembering? Would they benefit from, that Webster pack, dosette sort of boxes, alarm systems to help remember to take medication, being able to have that sort of large print or easy access to what their medications actually are is certainly worthwhile reviewing. And we're going to talk a little bit in a moment about some of the medication that might affect cognition as well, that we might have prescribed. So it's not just illicit drugs or alcohol, there's other things that we might have already prescribed that might affect somebody's cognition. So thinking about deprescribing actually might be what we're doing, as much as thinking about what else we might prescribe. There is a few deprescribing tools around. So the MatchD was one developed in Tasmania around specifically looking at dementia deprescribing and the stages of dementia. There's the Stop Start tool, which is a UK-based one, which you can also Google. And that's got some tips around deprescribing for older patients as well. And obviously your pharmacists are there to think about either home medication reviews or medication reviews in residential aged care as well. So that's a really useful resource, and certainly all the ones that we do up here in Brisbane, where I am, comes with the anticholinergic burden for each of the medications that a person is on. So Beck, do you want to talk us through that drug burden?
Yeah, look, I think this is really important and becoming probably even increasingly important. I think one of the questions earlier did talk about anticholinergic drug burden, because there is research now, new research actually showing that some types of anticholinergic medications seem associated with an increased dementia risk, well before the dementia has even developed, has even become apparent. So particularly tricyclic antidepressants and also the bladder antimuscarinics, there seems to be some sort of a link or association with use in earlier life and developing dementia. So I think that's also worth considering. But for the purposes of today's talk, which is more once a person has been given a diagnosis of a cognitive impairment, having a look at their medication to look for the anticholinergic drug burden is really important. And I like this chart. It's a bit wordy, but I think it does flag some really common medications that we use that actually have a very high anticholinergic burden. And, you know, it doesn't take much in our older patients who are on a beta blocker and some frusemide, and then they have a bit of amitriptyline at night, maybe a bit of oxybutynin for their bladder, maybe an antihistamine, and all of a sudden they have a very high anticholinergic burden. I worked in the geriatrics team, last year, and it was quite astounding the number of our elderly patients who came in who had quite elevated levels of anticholinergic drug burden. Amitriptyline and oxybutynin were definitely two of the real obvious ones to be mindful of. Other medications that can also affect cognition are opioids and some Parkinson's medications too. So it's just worth asking if there have been any recent medication changes or any new medications added as well. Yeah.
Thanks, Beck. What about specific medications for dementia?
So the ones that we have available currently, and there are some in sort of trial phases now in terms of actually modifying the disease of Alzheimer's pathology, but the medications that we have available to us now are largely the anticholinesterase inhibitors. So we're looking at particularly donepezil, which is Aricept, rivastigmine, and galantamine. These, in order to prescribe them, usually you would have a patient who has a mini-mental score of 25 or less, although there is some room to move, and a mini-mental score of greater than 10. And it should be done in consultation with a specialist. So if there's going to be a very long wait and you feel very comfortable and confident that the person does have an Alzheimer's type dementia, then you can always call and discuss it with the specialist. And the other thing to be mindful of is that there are certain conditions that we wouldn't recommend prescribing them in association with. So always do an ECG to check for any sort of bradycardia or heart block. So certain types of asthma and COPD and peptic ulcer disease also can be relative contraindications to using the cholinesterase inhibitors. And then on the next slide, we've got memantine. So in regards memantine, this works differently. And so actually sometimes you can use it in conjunction with the cholinesterase inhibitors, or sometimes if you've found that you've not had any success with the cholinesterase inhibitors, you can try the memantine instead. It's usually that moderate sort of stage 2 type dementia where the MMSE is between 10 and 14. It's generally worth sort of monitoring over about 6 months to see whether there has been an improvement in cognition, but also even an improvement in things like behavior changes. And so, you know, sometimes that in itself is sufficient for somebody to maintain the use of the medication. So it should be constantly in review. Yeah. Anything else to add to that, Karen?
I think the other thing is there's probably only about 30% of people that really get much of a benefit from them. So everybody wants to know about medication, but in actual fact, there's probably far more benefit by deprescribing some of the things that they might be on and looking at some of the other multidisciplinary things that we can do. There's much more likely to make a benefit than some of the medications that we use. So it's just worth keeping in mind. They're there, but they're not always brilliant for everybody.
Yeah, thanks. Yes, that's exactly right. And also, even if they do have an effect, it's really just it delays the progression. So it may slow things, but ultimately they'll end up on the same trajectory.
Probably the other thing to note is there's not really clear guidance of when to stop them. Probably around that stage 3 is when most people would stop any of these medications. And again, because you can have a dip in function with stopping. So it's that if we think it's having some benefit, we tend to just keep it going because in stopping it, we certainly can see a dip that doesn't always come back to that baseline when we restart it. So that's probably the only other caveat to using them.
Yeah, that was my experience with the geriatricians too. They would often continue it, particularly if they felt that it was assisting functional behaviour. Yeah.
So speaking of function, that's a nice segue. We're going to think about how else we can optimize somebody's function. And this is where you're using our allied health colleagues if, depending on the person's needs, can be really useful. So I've got a young patient at the moment and he's found some OT input to be invaluable in just helping set up things like his improved his GPS so he can still go bike riding and not get lost. He's got an alarm system, so when his family are out, he remembers to eat and drink. There's been, changes made in the kitchen to make it easier for him to do some of the simple things. So there's a lot of extra assistance that we can find for some of our patients, again, to keep them as independent for as long as possible. So really looking at what tasks are they doing well that we can maintain, what tasks are they needing extra assistance with. So it may be that we're looking at physio or exercise physio as part of that, maintaining strength, falls prevention, some of the things that might tip somebody off into not managing at home anymore. So really looking at, again, what the needs of the person is. And again, psychology is useful as well. So we know, particularly in stage 1 or MCI, using things like cognitive behavioural therapy is actually still very useful. So it is something that for both carers and the person living with dementia, psychology can also be useful. So it really comes down to that strength-based. What is the person struggling with? How can we actually assist them best? And for everybody, that might look different. It might be that somebody enjoys music therapy or something else completely, or looking at some of those social groups that we might be able to get people involved in. So the men's shed type things or choirs, a whole heap of different things that with that sort of social connection and or physical function is going to actually continue to maintain somebody's function and independence for a bit longer. Anything else you want to add to that, Beck?
No, I think that was good. Yeah, not happy with that.
Driving is always another thing that is a conversation that we need to have, and this certainly comes into function, and it certainly comes into safety, and that sort of stage 1, 2 we need to be very aware of. So it's not something that with a diagnosis of dementia you must stop driving immediately, but we do know that your driving days are numbered. So there will come a time, because it's a progressive disease, where driving cessation will need to happen. So having that conversation early and possibly repeatedly, not the first visit preferably, but having it early is actually better than waiting until there's a crisis. So as a minimum, we should have that diagnosis as a medical condition on their driving certificate. Again, depending on where they are within their journey, it might be that you're reassessing them in 3 months or 6 months rather than it being a 12 months that you might put for somebody that's older with no other medical issues. And again, that's going to be a little bit different state to state. So if you're concerned, definitely seek advice. Who to seek advice from? Well, certainly the OT assessment is kind of the gold standard. Some of our geriatricians are also happy to be the bad people and take licenses away if we're not feeling comfortable doing that. So if you're just not sure, what we don't want is, for licenses to be given for both the person who's living with dementia for their safety, but the community safety as well. And this is often where it's tricky for us, because normally we're the patient advocate for everything. And in this case, we need to be aware of the patient, but also we need to be a community advocate. So really looking at that safety. There's no one really easy way of testing in your room how someone is, but there's a few things that we can do that might help give us a clue. So we know that what's most correlated with future accidents is actually having had an accident already, or near misses. So that's definitely worth asking about in your consultations. Any family concerns should certainly make us very aware that, again, there might be an issue with somebody's driving. The MMSE is not great at predicting how someone is driving, particularly if it's over 20. That really doesn't give us a lot of information at all. Some of the other tests that we can do beyond looking at their physical function is doing things like the visuospatial sort of tests, so either the Trail A and B or the Snellgrove Maze. If you haven't seen those, we'll put those up in a sec just to show you what that looks like. The clock drawing test can give us a little bit of an idea about that sort of visual, spatial and executive function. And the intersecting pentagons, same sort of thing. I've started, in Queensland we have to do an assessment for everybody that's over 75 every year. So I've started actually incorporating some of these into my assessments, and every now and again I'm actually surprised. I did have someone try and cheat their clock drawing test using their watch and still had difficulties. So needless to say, their driving license has not been renewed at this point. So it is something that, you know, we can use some of these things to help us make a decision, but it's very difficult, you know, without seeing someone on the road. If you've got concerns with any of these, we certainly want to get that next lot of assessment. So if you haven't seen it, you can just download them from Google. So there's the Trail A and B test. The Trail A, they start at 1 and just follow sequentially the numbers. And it's a time test, so they're meant to be able to do it, you know, in less than 2 minutes and make no errors for you to be happy that they're safe. The Trail B is actually I prefer, because it's similar to the beginning of the mocker, but it is you've got to remember what the task is, which is to go 1A, 2B, 3C. So they've got to hold the task in their mind and then switch between numbers and letters. And it is something that probably most mimics what might happen on the road, where somebody's not only got to be driving, but they've got to be aware of pedestrians or other cars coming in, stoplights. So being able to task switch while maintaining a task. So I quite like the Trail B. This is the sample one, so you show them how to do it, and then the full one is a full A4 page, which again, it's a timed test. So they should be able, if they can do it in less than 2 minutes, make less than 2 errors, they're probably okay. If they're making 2 or more errors or taking more than 3 minutes, they're probably not okay, or at least they need to, you know, consider an OT assessment. Snellgrove Maze, again,
I think
for somebody.
that was sorry, I think that was the Trail A, that one, just so you know.
So it is. Yeah, the B has 1 and then an A and then a 2 and then a B. Look at that. I've put the wrong picture in.
Sorry.
No, thanks. I didn't notice. So the Snellgrove Maze is good for somebody that might not have the literacy to be able to do 1s and A's and B's, because obviously we need to be aware of that might impact somebody's results. So again, they should be able to get through this maze. It's timed without sort of making errors. So again, it's a task holding and sort of visuospatial task. So it's another one that you could consider doing.
It's also good, I think, because you've got a baseline time as well, you know, and so if there are problems, you know, in the future, you can look back and say, well, you know, last time you managed this in 20 seconds and now it's taking you a minute, etc. So I think it provides a baseline from the start as well.
And one of the complaints we often get around OT assessments is the cost. And we do recognise that they are costly because they spend time with people first assessing them and doing that assessment first, then spend time on the road and then give us a report that we can use. But it does become the cost of having a car on the road. So just like registration and petrol and insurance, if a person does want to drive and we have concerns, it is a cost that we need to have. Some of the road licensing authorities do some driving tests. It's probably not as safe for them or for the person because there's no assessment beforehand. They're really just looking at driving. If that's all you have in your area, that's probably better than nothing. But again, from a safety side of things, the OTs won't take someone on the road if they don't think they're safe. So just to be aware of the differences between the two. Beck, some of the other legal things that we might consider under that sort of function.
Yeah, and I think this is a good example of the reason why if we can make a diagnosis early, it's even better. And I don't know about you, Karen, but you know, I'd recommend even just as a standard in your over 75 health assessment, unrelated to dementia, that these things also be discussed, because ideally, if we can get it done before there's any sort of cognitive impairment, that's the best time. So just making sure from an early stage that things such as a will, enduring power of attorney, and enduring guardian have all been discussed and signed off on. And also talking about an advanced care directive, because I think certainly early in the diagnosis, this is an opportunity for the person living with dementia to really tell their treating team and tell their family what they would like. And so trying to get that in early, while capacity is generally not such an issue, is really important. I think different states have slightly different terminologies, but essentially you need to appoint somebody who is able to make decisions on your behalf in regards lifestyle and health and in regards to your finances.
So it's a question about what stage you feel there's no longer capacity. It comes down to that capacity is all about the task in front of them. So we certainly want to encourage the diagnosis making, if possible, in that stage 1 where they're more likely to have capacity. Certainly by stage 2, and there often isn't, but it comes down to that task that you're asking them about. So they may have the capacity to do one and not the other. And what we're really looking for in capacity, my capacity in 3 points, because it's a whole nother workshop on its own, but they really need to be able to understand the implications of the decision that they're making, the pros and cons. They need to be making it voluntarily, so not dragged in by a family member to make it, and they need to be able to communicate that decision and the pros and cons back to you. So it might be that they can certainly make in stage 2 decisions around an EPOA and still understand that, but you may not have the capacity around will. So again, the sooner we do that, the better. So for each decision, that's a separate capacity assessment. So capacity is very much decision specific, if that makes sense.
Yeah. And where possible, even if a person doesn't necessarily have capacity, where possible, involving them still in the decision making is important. That makes
I've had a few patients that have come into the nursing home in that sort of stage 2 messy part of that trajectory graph where they've had falls or a partner's passed away and they're no longer coping at home, and suddenly the family realised that the will was, the ex-wife from 20 years ago, and we can't change it. They don't have the capacity to make that decision anymore because they don't understand what finances they have, what that implication looks like. So it is something that if we can make this diagnosis earlier, we have a chance of being able to look at some of these things.
So in terms of family and carer support, we have alluded to it already, but I mean, it can be incredibly, it's an incredibly hard thing, I think, as a family member and as a carer, to look after a person living with dementia. And often it can be quite isolating as well. And interestingly, Karen, the Lancet report that you did, that was sort of, I think Jill Livingstone sort of ran that. And I sat next to a psychologist the other day who had actually worked with Jill Livingstone. Apparently, she gives a referral to a psychologist for every carer that comes in at the first consultation. So that really resonated, and I think it's really important that we consider the mental health of carers sort of from the very get-go. We've already discussed places that they can seek education, and I think even just sometimes having a fairly regular appointment just to touch base and make them feel not so alone can be really helpful. There are also there is good help available through Dementia Support Australia. And so if we have a look, here on this slide, there's a phone number that carers and family can call 24 hours a day. There's also a phone number that health professionals can call. And so potentially people can come and visit the person in the community or in a residential aged care facility and provide some advice on potentially on changed behaviours and expressions of unmet need. So this is another helpful thing to have up the sleeve.
What about that physical domain, Beck?
I think this is the other really important thing that as GPs we can be great helps with, because often a person will receive a diagnosis with the geriatrician, and in my experience often they get the diagnosis and really then they're sent home with not much information and perhaps, you know, a follow-up appointment in 6 months. And so as the GP, we're left really now with managing this person who's got quite a life-changing diagnosis. And I think there is a lot that we can do. We've already talked about a lot of it, but preparing a general practice management plan, so providing a good half an hour appointment, sometimes even an hour, just to go over everything that's needed on that checklist. But particularly looking now at physical health, looking at the other chronic diseases that the person might be experiencing and managing them appropriately, but particularly also looking to areas of frailty. So assessing weight and monitoring weight quite carefully. Weight can be a real indicator to us that perhaps a person's not looking after themselves as well, and so, or, you know, that their appetite's off. And so, you know, this is where a referral to a dietitian might be beneficial, looking to nutritional supplements, etc. I always recommend early in the piece a bone density scan if they haven't had one, because again, we know that people living with dementia are at an increased risk of falls. So, you know, looking at bone health, making sure their calcium and their vitamin D intake is adequate. Another area that's often sort of skipped over or forgotten is dental health. And so, again, a referral to a dentist is a really good idea, particularly if they're going to be starting on Prolia. It's a good time to get a dental review. But the other thing is, once they've moved into a residential care facility, it's often very hard to get them to a dentist. And so making sure their teeth are good is very important. In terms
my other tip around that would be, again, from a changed behaviours, if you're going into residential aged care, always pull the dentures out, because quite often ulcers and dental issues can be a cause of, you know, pain when we can't identify any other reasons. So dentition is, and it's certainly much easier to sort that out earlier rather than later in somebody's journey. So
yeah, and it's another reason why they might not want to eat. You know, it can often be related to they can't find their dentures, or they're causing them pain, so less likely to eat and thus losing weight as well. I also think it's important to check for other sensory impairments. So assessment of vision, making sure that their glasses are in reach and that they're appropriate, and of course hearing impairment, which we've covered a few times. But if we can intervene early and encourage a person to be using their hearing aids all the time from an early part of the diagnosis, that can be really helpful too, you know, down the track. So addressing hearing and vision, and also other peripheral neuropathies and that sort of thing, can be really helpful. Dietitian, speech pathology, as allied health practitioners, can also help in terms of swallowing and nutrition. And then the other thing about general management plan is that we review it. And so it does need to be, you know, fairly frequently checked, because I think, as Karen's just about to tell you, again, with the stages, there will be different requirements. Take it away.
Yeah, so most of that was really looking at that sort of stage 1 management. Stage 2 and stage 3, as we said, the goals really change, and we won't re-go through those tonight because they're really two separate workshops again, but really thinking about, you know, those physical changes in stage 2, and then perhaps the behavioural changes that may need to be addressed in a different way, and certainly being aware of that potential mental health impact along the way. By stage 3, when we're looking at comfort, we're certainly looking more around, you know, that deprescribing, not, you know, managing some of those things like nutrition and mobility, but actually not in that same intensive way as we are in stage 1. So as we come to a close, we are going to have some time for questions, but hopefully you'll take away that there are modifiable risk factors, and you can start thinking about those even as early as those 45 to 49-year-old health checks, or much earlier in life, rather than just when somebody has a diagnosis, although it's not too late at that point. That there are things that we can do both in the diagnosis and management for someone living with dementia, and that there are certainly interventions that we can do that do make a difference for their quality of life and for the quality of life of their care partners or the people around them who are supporting them. If you haven't had a look after last week, there is the Dementia Training Australia website, which has got, again, lots of resources for GPs specifically. It's also got a link to the Dementia in Practice podcast, which really gives us a deeper dive into lots of those different topics. So there's season 1 and 2, there's number 3 will be released soon, but there's heaps more around driving, around sleep, a whole heap, some younger onset dementias, a whole heap of just interesting, easy to listen to deeper dives into dementia if you're interested. We're going to pass over around health pathways, because you don't need to remember everything we've said tonight, because most of it you will find in your health pathways. And I might stop sharing my screen and let Kim or Sharon take over.
It will be Sharon.
Excellent.
I'll just share my screen. I'll go through the last slides. If anyone's got any questions, they can put it in the Q&A chat and we will answer those. I'll just go here. So just thank you, Karen and Rebecca, for that. That was great. So resources. So this page here is just the resources for Illawarra, Shoalhaven and Southern East New South Wales. So the coordinator. So you can take a copy, a picture of these if you want, but you will find the
screen shared, Sharon.
Oh,
so
sorry. Okay, I have to. Okay, sorry. There. So this one is just for Illawarra and Shoalhaven and Southern Eastern New South Wales. You can take a picture if you want of these, but you can find these resources on the Coordinator site under for health professionals. And on slide 9, these are from CHN. PH in. So there's your link. Again, you can find them on the site under for health professionals. They're printable, and we have got like flyers if you want some sent out. So you can just contact the Health Pathway team, or you can just go through CHM and we can send them out. On every health pathway, so there's 8 clinical dementia pathways and 2 resources, but on the 8 clinical pathways, on the bottom right hand side of every pathway there's send feedback. So if there's a service that we haven't got, or there's information you want added or not there, or you don't think's correct, if you just do feedback, we can respond quite timely to that. And thank you very much for attending today. And there is your QR code for the evaluation. And I think that's where you have to put your whole profile, your name, when you fill that out, please. Thank you. Is there anything else?
A question in the Q&A about, I might throw this one to you, Beck. So the impact of family history. Impact of family history as a risk factor, and I guess the question is, are you meaning the impact, the psychological impact on the person, or using family history as a risk factor tool? I'm not entirely sure, but I'm going to throw it to you anyway, Beck.
I think the earlier question was just saying that it hadn't been included as a risk factor. So I think it hadn't been included in that Lancet survey just because it's not a modifiable risk factor. Certainly we know that there are some genetic forms of Alzheimer's disease particularly, although these make up a very small percentage. These specific genetic forms make up a very small percentage of the familial types of Alzheimer's disease. I think we're looking in sort of the 1 to 2%, and people will tend to present with a younger onset dementia. And yeah, so there are some genetic predispositions. We do know that the ApoE4 allele does predispose also to an increased risk of Alzheimer's disease. So people who carry one ApoE4 as opposed to ApoE2 or ApoE3 are at a greater risk. And if you're carrying 2, like Chris Hemsworth, for example, then the risk is significantly increased 9 to 12-fold. But generally, in clinical practice, we don't check the ApoE4 status. In research, certainly, often the ApoE4 status is noted because there is such an increased risk for those carrying the 2 ApoE4 alleles. Yes, does that somewhat cover the answer? What do you have anything further to add to that, Karen?
No, I think it is worth being aware of for that small group of patients. I've certainly got an autosomal dominant form in a patient whose mother also had it, and I look after the daughter. So it is something that, from a psychological impact, we're very aware that should she end up developing any symptoms, that's going to create some havoc. But yeah, I think, again, it's worth being aware of. They're definitely the people you want to get onto the other modifiable risk factors as early as possible. Any other questions in the... Oh, we have 9 minutes remaining. If not, you can use this time to complete your evaluation form. It's always easier to do it at the time. So, question for you, Beck. How do family and GP proceed with diagnostic workup or exclusion of organic causes in a non-insightful, challenging person?
It can be very difficult, can't it? It can be really hard. And, And from what I've experienced and from what I've seen, unfortunately, sometimes it is a matter, unfortunately, of waiting for a crisis to occur. I mean, where possible, you do everything that you can to try and to try and appease the patient and just see if you can work with them. But I mean, sometimes it is a matter of a crisis occurring. Yeah, and they will end up in hospital, and and guardianship board, etc., sort of ensues. I don't know. Have you had any thoughts or experience on that?
Often I find I can get the investigations done. It's the management from that. So as long as I'm not mentioning dementia for some of these patients, I can get some of those investigations ruled out. Think about medication, but yeah, it's very difficult if you've got a difficult personality and no insight. And as Beck said, yeah, often, unfortunately, you're waiting for a crisis to be able to enact change. Thankfully, that's not too often, but.
No, I mean, I have seen a couple of cases where the person had to be detained, but again, that's not really that. They're sort of, I think, exceptions to the rule, really. But it's hard.
So there's a question about how to best manage very disruptive behaviours, agitation, distress, residential aged care and Lewy body dementia when we're trying to avoid antipsychotics. It's again another webinar in itself, but assuming you've kind of ruled out organic causes, you've looked at how you can manage the environment, and that's often the tricky thing with staffing or understaffing. There's actually better evidence for the cholinesterase inhibitors, actually, even though it's not on the PBS. And then quetiapine is probably the backup that some of the geriatricians would use. I don't know if you've got anything else to add to that, Beck. It's tricky.
No, that's what I would say too. And again, Dementia Support Australia, for those really tricky cases, call the GP line, and in those really tricky cases, then a geriatrician can come out to the facility and provide some other sort of suggestions. But once again, we're talking the real exception.
They will come out and do staff training as well, and that often is also valuable. So apart from looking at what else you could put in place and, other things like pain or other, common triggers for that behaviour, they will also give the staff ideas of how to manage it. And I found that part of it has probably been the most useful because it just gives staff extra kind of strategies to manage some of the behaviours rather than looking purely for medication. But if there are safety concerns to the person or to residents or staff, then obviously medication needs to be considered.
And whilst benzodiazepines are not really recognised as a treatment, I think again that with geriatrician review, they may have a role. On our Dementia Training Australia page, there is a whole sort of teaching module on use of benzodiazepines in persons living with dementia. That might be a worthwhile thing to have a little look at too.
Any final questions?
Okay, if there's no more questions, I might just take this opportunity to really thank our speakers for the session a couple of weeks ago and today. I think it was fabulous. And, please take the time to complete your evaluation form. There will be a follow-up email that comes out, which will have the form there as well if you can't complete it this evening. And any questions or queries that you might have, any interest in other topics relating to dementia, just pop them on your form and we'll be able to follow that up when we review them. And sorry for my background. It's taken me an hour and a half to actually log on and get sorted. So take care and have a lovely evening.
Thanks, Kim.
Thank you.